Welcome, everybody. And I am in California, so I'm going to say good afternoon. So I don't know where you are coming from the rest of the country, but good afternoon. And thank you so much for being here today. We actually want to make sure that we know where everybody's coming from. So please feel free to write in your name in the chat and also where you're located as well. So thank you so much for being here. And so you are here in the right place. The next learning session is Intersections of Behavioral Health and Housing Needs, Connecting Clients to Systems of Care. And so we also want to make sure that this is a very interactive participation from the audience. And we're going to be asking you to just make sure that you write in any questions to the presenters. There is going to be an opportunity for questions and answers at the end of the presentation. We also want to remind everybody that everybody's microphones are off and the session's also being recorded. I know you probably heard the sound as far as like the session's being recorded. And also the handouts and slide deck are also going to be, they're available for you as well. And at the end of today's presentation, we're also going to be putting in a survey at the end in the chat so that you can actually give us information about your learning experience, any other tips or opportunities that you would like to learn more about. Next slide. You know, we are here to, this presentation is actually, does not necessarily reflect those of our funder, the California Department of Healthcare Services, or our CARE TA, Center Partner Agencies listed below. We also want to remind that this is a very safe place for everybody, and in the event of any security issues that may occur, the session is going to be immediately terminated and will not resume. A separate email is going to be sent to all participants with further instructions. Next slide. We also want to remind everybody that we are here to listen, learn, and lead, and have the opportunity to be able to make sure that there is participation from the audience. Please use the chat box to message the speakers as well. Whenever you're writing any information in the chat box, use I statements in the chat and avoid making any comments that are stigmatizing or otherwise injurious towards others. If you do not want to engage in the chat in the future, it's okay. You can minimize it and just enjoy the conversation we're going to have today as well. And also, if you need to have an opportunity to take a break, we also invite you that there is an opportunity for you to get out of the session and join any of the quiet rooms that are available for you today. Next slide. And now it's time to begin the presentation. And I have the honor of introducing Alicia and Patricia to offer you some learning opportunities today. So welcome.
Thank you so much, Angela. My name is Alicia Lemer. I am a senior policy analyst with Homebase, which is a nonprofit that supports communities with developing their responses to homelessness. We work in communities and states across the country, but we are based in San Francisco, California. And my pronouns are she and her. I'm going to hand it over to my colleague.
Thanks, Alicia. My name is Patricia Stewart. I'm also a policy analyst with Homebase. And yeah, we're just going to go ahead and jump right in. And my pronouns are also she, her. So today we're hoping that you walk away with a few pieces of knowledge that might help you in your day-to-day work. And those include learning about the connections between the social issues of homelessness, housing, and behavioral health, gaining some context on local homeless systems of care and how to provide connections for clients experiencing a housing crisis. And we hope you leave here today with a greater understanding of the importance of equity as a lens for serving different populations with overlapping behavioral health and housing needs. We also hope to engage in conversation during this presentation and beyond about how to support the behavioral health and housing needs of your clients. So first, we want to provide some context on the intersections between homelessness, housing, and behavioral health. As many of us here today may recognize, housing is fundamental to health and well-being. So a big part of what we will explain today is how these two realms, housing and healthcare, intersect and can coordinate for the sake of supporting the healthcare and housing needs of people in our communities. So first, we're just going to provide some high-level data on the size of homelessness as a national issue. Over 580,000 people experience homelessness in the US on experienced homelessness in the US on any given night in 2020. In relation to the intersections between homelessness and behavioral health issues, of those 580,000, 27% were experiencing chronic homelessness in 2020. Chronic homelessness refers to an individual with a disability who has been continuously homeless for a year or more, or has experienced at least 4 episodes of homelessness in the last 3 years, where the combined length of time homeless on those occasions was at least 12 months. A disability includes physical health conditions, mental health, substance use, and behavioral health. And finally, around 45% of those experiencing homelessness in 2020 were living with a mental health condition. Homelessness, housing, and health are interrelated. In the field of homelessness, we often see housing instability and health needs as cyclical issues. Physical health conditions, mental health conditions, adverse childhood experiences, and substance use disorders are all risk factors for homelessness. At the same time, the experience of homelessness increases the risk of poorer physical and behavioral health outcomes. So people experiencing homelessness have high rates of infectious and acute illnesses like skin diseases, tuberculosis, chronic diseases, mental health conditions, and substance abuse disorders, as well as being victimized by violence. In addition, the mortality rate is 3 to 4 times higher for people experiencing homelessness than for the general population. Programs that provide long-term stable housing for people experiencing homelessness can help to improve physical and behavioral health outcomes, including reducing the number of visits to inpatient psychiatric hospitals. Homelessness prevention resources are particularly important because they can help avoid the cycle of housing and health instability we often see once an individual or household loses their housing and experiences homelessness. The COVID-19 crisis made it clearer than ever that housing is healthcare and homelessness is a public health crisis. The shelter-in-place and stay-at-home orders were difficult, if not impossible, for most people experiencing homelessness to follow. It is always difficult for people experiencing homelessness to find safe places to take shelter, but this was exacerbated by the pandemic. Residing in unsheltered situations or in congregate settings also increased exposure, risk, and vulnerability to the spread of COVID-19 for persons experiencing homelessness. People residing in unsheltered situations, such as on the street or encampments, have particularly limited access to sanitation tools like clean water, soap, and hand sanitizer to help protect themselves and prevent the spread of the virus. Due to the increased risk of spread in congregate settings, access to shelters, food pantries, and other emergency services were limited. However, we did see a move towards non-congregate shelter in hotels and other similar sites that helped keep people safe and move them out of unsheltered situations. We also saw distinct behavioral health impacts on people experiencing homelessness due to the pandemic, including increased stress, anxiety, isolation, loneliness, substance use, and difficulties in managing substance use and mental health needs. Vaccine distribution has helped to protect people experiencing homelessness from the virus, but there are still distinct challenges in reaching persons experiencing homelessness, particularly those in unsheltered situations. There's also understandable concern and medical distrust that has resulted in vaccine hesitancy for some people. For the homeless response system, the COVID-19 crisis has brought challenges, but also new funding opportunities and protections for people at risk of homelessness. One key protection has been eviction moratoriums, which we'll discuss in more detail next. An eviction moratorium is a temporary halt on the ability of landlords and property managers to evict renters due of no payment of rent. This step was taken by governments at the local, state, and national level, including an ongoing eviction moratorium by the CDC to keep residents in their homes and help mitigate the spread of COVID-19 during the height of the pandemic. Evicting renters from their homes may force them into crowded environments like homeless shelters or the homes of friends or family members where they would be at an increased risk of contracting or spreading COVID-19. Individuals without secure housing are often forced to move often, occupying whatever space is available, which may also increase their exposure to the virus in different and possibly more crowded environments. If they have coronavirus at the time of a move, they could unknowingly infect others. So these measures have helped keep low-income renters safe from housing and health instability throughout the COVID-19 crisis. It also helped to mitigate anxiety, stress, and other mental health concerns that can arise when faced with eviction and the threat of homelessness. However, With COVID-19 cases on the decline and vaccinations on the rise, a number of localities are lifting their eviction moratoriums, and the federal CDC moratorium is set to end on June 30th. Because of this, we're bracing ourselves for a significant increase in evictions, entries into homelessness, and behavioral health needs among people currently in unstable living situations. So because of this potential eviction crisis, we want to support cross-systems partnerships that go from prevention all the way through housing stability, which includes the prevention efforts, meeting people where they are with services, connecting clients to supportive housing, and ongoing support for clients who were formerly homeless. Due to things like the eviction moratorium during COVID, we've had the chance to see how we can help prevent homelessness among people at risk. Now we have the opportunity to expand that by collaborating at multiple points in people's experiences to help stabilize them and break the cycle of housing and health instability. At this point, you may be wondering how the homeless response system works and how we can achieve this collaboration between housing and healthcare. For this next section, we'll elaborate on what local homeless response systems are and how you can connect to them. First, these are the primary funding sources for homeless and housing programs. They include the U.S. Department of Housing and Urban Development's funding, which is about just under $3 billion in federal funding annually to prevent and address homelessness. They include continuum of care funding, and we'll talk about what a continuum of care is, which is awarded annually for over 6,500 local homeless and housing service programs across the US. And it also includes Emergency Solutions Grant, the Emergency Solutions Grant Program, which is another $280 million awarded annually to states and cities and counties to provide outreach, shelter, and housing. But also during the COVID-19 pandemic, we saw an influx of additional resources and opportunities. So now, as promised, we'll get into what a continuum of care is. So a COC, or continuum of care, is a regional or local planning body that manages HUD-funded housing and services provided to persons experiencing homelessness in the area. So this could be at different geographic levels, like a city in the surrounding county, a state, or a region. For example, a lot of rural counties will all combine together into one large region as a COC. The purpose of a COC is to promote a structured and strategic approach to housing and services, to manage year-round planning efforts, to prepare and submit applications for funding, to conduct an annual count of all persons experiencing homelessness, known as the point-in-time count, to develop written standards and performance targets for programs, and much, much more. Basically, it's a large system of care in a region that helps to coordinate and structure and organize all of the homelessness-related funding and services in the area. So a COC is intended to be a large representative group ranging from nonprofit homeless providers to victim service providers, people with lived experience, faith-based organizations, school districts, advocates, governments, and the reason why we're here today, health and behavioral health providers. So next I'm going to hand it off to Alicia to walk through this next section, getting a little bit more into these connections to continuums of care.
Thank you so much, Katricia. And if you can go to the next slide. So now we have an understanding of how the homeless response system is funded and structured. I'd really like to delve into who is served. And while I do that, if you already have a connection to your COC, feel free to share in the chat, how that is already, how you're collaborating. We would love to hear your feedback. So in general, the homeless response system serves clients who meet the HUD definition of homelessness, which prioritizes people who are experiencing literal and unsheltered homelessness. This includes people who are sleeping on the street, in a tent, in a park, or in a car, sleeping in an RV or in an abandoned building that is not hooked up to utilities, sleeping in a dormitory-style emergency shelter, or sleeping in jail or in the emergency room for just a couple of nights, and then going back to sleeping outside. So what this means is that people who are in precarious or unsafe housing situations that may qualify as homeless under other definitions. So there are definitions at the local and state level. There's also definitions for other departments like the Department of Education. Those definitions, such as being doubled up, couch surfing, residing in sober living homes, and residing in motels in which the client is paying for that motel, they're not often prioritized for many of the resources in the homeless response system, particularly through the COC and ESG programs. One exception to that is that these people may be eligible for homeless prevention assistance through the ESG program or other similar resources. As Katricia mentioned, we've seen some new resources emerge during the COVID-19 crisis, and some of those are really dedicated towards prevention. The reason that prioritization of people who are literally homeless is kind of what we see throughout the homeless response system is that there are very limited resources. Therefore, HUD and HUD-funded projects seek to prioritize those individuals who have been homeless the longest and who are in situations that create the most vulnerability and risk to their overall health and well-being. Next slide, please. So within these eligible populations, we often see communities and projects prioritize specific populations of focus for homeless and housing resources. As you can see here, this includes populations such as veterans, persons living with HIV/AIDS, survivors of domestic violence, unaccompanied youth, and families. It also includes a number of populations that have significant crossover with the behavioral health system, including persons with severe mental illness, persons experiencing chronic homelessness, and persons experiencing a substance use disorder. This highlights an important opportunity for collaboration between behavioral health, and homeless service providers, which is putting into place data sharing agreements to help identify and serve those clients that are being seen and served already by both systems of care. So really getting that coordination in place. So in addition to that, when we're thinking about who is served in the homeless response system, we also really want to make sure that we are considering equity and equitable representation in all of the aspects of our work, from outreach to service delivery to housing placement. We know that Black, Indigenous, and people of color experience homelessness at higher rates than white persons. The most striking disparity we see is among Black and African American adults, who represent only 13% of the general population, but account for 39% of people experiencing homelessness and more than 50% of homeless families with children. This is a result of long-standing systemic inequities that impact rates of poverty, housing discrimination, involvement with criminal and legal systems, and other effects of discrimination and racism that increase the risk of homelessness. Homelessness also disproportionately impacts lesbian, gay, bisexual, transgender, and queer persons at higher rates than straight and cisgender persons. 17% of LGBTQ+ adults reported ever experiencing homelessness in their lifetime, which is twice the rate of the general population. We also know that LGBTQ+ youth are disproportionately represented among youth experiencing homelessness. This is a good reminder that in our work, we need to consider intersectional experiences and identities, including race, gender identity, and sexual orientation. Those experiences and identities that are prioritized by HUD and the homeless response system already, such as veterans, youth, and persons experiencing chronic homelessness. And those with experiences that create additional vulnerabilities that may result in homelessness, such as engagement in sex work and histories of involvement with criminal and legal systems. Next slide. So in order to best serve our clients with behavioral health needs who are experiencing homelessness in an equitable manner, there are a couple of models that we can incorporate into our programs that we're going to highlight now. One is the authentic engagement of persons with lived experience in service design, development, and implementation. There are a number of ways this can be achieved, and that we're seeing this emerge in both the homeless and behavioral health systems, including through lived experience advisory boards, consumer feedback processes, and ensuring representation of persons with lived experience as part of your program staff and boards. This also brings us to another equitable model of service provision that we've seen across systems, which is peer supports. I'm sure that a lot of people on the call right now already know about peer supports. You are probably using them in your programs, but those are when people use their own experiences to help others to achieve their goals and to increase greater stability. The behavioral health system has been a really great model for this, and we in the homeless system have been incorporating lessons from mental health and substance use peer models. Some of the peer models that we have on here include peer support groups, one-on-one individual support and case management between persons with shared experiences, and the employment of peer support specialists. But really, we've seen the ability to incorporate peers throughout all of our service models. And I see we love our peer supports. Yes, that is amazing. Thank you, Sasha. And we also know that peer supports can take a lot of forms. They may be volunteer positions. We really want to see an increase in paid staff positions for peers. We are really working on that in the homeless response system, and I know there's a lot of movement on that in the behavioral health system as well. Finally, both the homeless response system and behavioral health system really recognize the importance of community-based services to meeting people where they are in their own communities and providing equitable access to services. So really recognizing this as an equitable program model. A few examples of these, and once again, you might be using this in your own programs, are assertive community treatment, which offers customized community-based services for people living with mental illness, and community-based permanent and affordable housing options. So we're going to delve into the housing options and other service models in just a little bit. But first, I want to provide some important information on how clients are connected to resources through the homeless response system. So a lot of times, providers from different systems of care or members of the general public really think about how to make that connection for a client to an individual program or service provider. However, the majority of homeless resources in the community, especially those that are funded by HUD, are accessed through a local coordinated entry system. Every COC has a coordinated entry system because it's one of HUD's requirements. The purpose of coordinated entry is to create a streamlined process for allocating homeless housing and other service resources in your community, with a focus on prioritizing those individuals with the highest needs and the most significant vulnerabilities. The goal of coordinated entry is to shift from having a network of largely disconnected projects that are making individual decisions about who gets access to housing and services and when they get access, and using their own criteria, which might not be consistent, to having an integrated homeless response where the decisions are made in a consistent way that align with local priorities. One important thing to note, however, is that not all resources in the community are required to go through coordinated entry. This is particularly true for homelessness prevention resources, emergency response, and non-HUD funded programs. So if you have any faith-based services in your community, those might not be operating, and you still have to have those one-on-one connections as well. Next slide. So this slide delves deeper into the different components of coordinated entry and the places where behavioral health providers can collaborate in the process. I want to acknowledge the coordinated entry could be an entire presentation by itself. It is a huge topic. So we are trying to give you some of the bite-sized morsels of what does it do and where are those opportunities to connect. And so coordinated entry begins with system entry, which is when a client is seeking housing or services and first enters the homeless response system through an access point. This could be a physical location, or it could be virtual, such as a hotline. So behavioral health providers, one of the first things you can do is you can know the access points in your community so that you can make referrals for your clients. But we also want to encourage you that you can work with the COC and think about being an access point yourself. There are a lot of access points that are really creative and that make sure that that access is equitable. Once again, we want to focus on equity. So we've seen access points in school districts and in, sometimes street outreach providers serve as access points. So lots of different ways you can connect there. So once a client has entered the system, their needs and vulnerability are assessed using a standardized process. So one way that you can connect to this part of the coordinated entry system is to work with your COC to learn more about the assessment tool or tools that are being used in your community, and to access training for staff on conducting the assessment with your clients. I also want to just call out that a lot of communities are reevaluating their assessment tool right now. So this is a great time to get involved and make sure that behavioral health considerations are part of that assessment. Once a client is assessed, they are prioritized for housing and services based on a set of factors agreed upon by the community. Many communities conduct case conferencing to help prioritize clients, and that can include a wide range of providers who are serving that client. You can participate in case conferencing for your clients if that's happening in your community. And if it's not, then you can advocate for case conferencing to be part of the coordinated entry process. I know that if you're not already connected to your COC, it's a couple steps removed, but just really thinking about all of the amazing expertise you bring to this. And you also bring that knowledge of your clients. So if you know they are being served by the homeless response system, you can bring all of that to those meetings. So once a client is assessed, they're prioritized, they're going to eventually reach the top of the priority list. And then they are given a choice of available housing options for which they are eligible and which appear to meet their needs. Once that client is matched with an appropriate program, they are referred to the program. As you can see on the slide, there are a lot of opportunities for collaboration here. And that includes supporting clients in identifying housing options that meet their behavioral health needs, helping clients to obtain documents to qualify for specific housing opportunities and public benefits, and to offer behavioral health support throughout the housing search process. We know searching for housing, it can be a really stressful, demanding process. So being able to be there for your clients is always something it's always a part of the process. So then the final step in coordinated entry is that the client is placed into the housing that they identified and that they feel like is the right match for them. And then our goal is to keep that client stable and safe in that placement and really improve their health and wellness outcomes. So at that point, your client may need ongoing behavioral health supports, and they also might need help with transportation to and from behavioral health care as needed. Once again, those are areas where you can play a really critical role. Okay, so I know we've already presented you with a ton of information on the homeless response system and how it works. And also just acknowledging that this is like Crash Course 101. So we are hoping to provide even more information in the future and delve into all of these pieces a little deeper. So we are at the point where this slide gets to that last really important piece of the puzzle, which is what are the programs that comprise the homeless response system? So we really broke them down into 3 buckets here. The first being those that help people identify or maintain stable housing outside of the homeless response system. And that includes homelessness prevention and shelter diversion. Homelessness prevention is designed to help clients maintain housing and prevent an experience of homelessness, whereas shelter diversion is designed to help people quickly identify alternative housing options, such as safe housing options with their family or friends, after a housing crisis has occurred, but before they enter the homeless response system. So the second bucket of interventions that we have provide emergency or temporary support. So this is, you've entered the homeless response system, or you are being entered into the homeless response system, and these are those emergency services. That includes street outreach, which is designed to reach people in unsheltered situations and connect them to shelter, housing, and services. And then you have emergency shelter, which provides a place for people to temporarily stay and receive needed services and basic needs while they find a permanent place to live. Transitional housing is a little different. It can provide shelter for a longer term, but it's also designed to be temporary, usually up to 24 months, in order to help people stabilize and move on to permanent housing options. The third kind of bucket of interventions are those that offer safe and stable permanent housing environments. So we have 2 models we've highlighted here. Rapid rehousing, which provides short-term rental assistance and supports, usually for 24 months, but this is different from transitional housing in that it's designed to quickly stabilize clients in their housing situation and connect them to community-based supports so that they can maintain their permanent housing on their own. So it's 24 months of, really it's financial support and supportive services, but then really helping clients transition into providing their housing on their own. On the other end of this, we have permanent supportive housing, which is designed to be non-time limited and offers intensive supportive services for persons experiencing homelessness who have a disabling condition, which, as Katricia mentioned earlier, may include mental health or chronic substance use conditions. So people experiencing homelessness don't have to go through this entire continuum of services. You don't have to try to do homeless prevention and then go through the shelter. You could go right from unsheltered homelessness to permanent housing, or you may spend some time in emergency shelter or transitional housing before moving on to permanent housing options. It's dependent on the client's needs, their comfort, and their preference with different options, as well as the availability of housing resources in the community. However, the goal of all housing and homeless interventions is to connect people with safe, stable, and affordable housing. And whether that's within the system or that's without, that's connecting back with family and friends, that's going to look different for every client, and each client's path to that looks different. So we're going to switch from this to the next few slides, providing some important information on places where behavioral health providers can connect to these different types of programs and program models. Also, I see there are questions coming in, and we will be getting to those in just a second. And so, as we mentioned earlier, homeless prevention is a huge connection point right now. There's a lot of focus on this because homeless prevention resources are one of the ways that we're going to respond when those eviction moratoriums come to an end soon. And they are coming to an end in a lot of communities already. We have seen the national moratorium extended quite a few times. The next deadline is June 30th, and we haven't heard anything about extensions. So we are all bracing ourselves and making sure that we are ready when people have those needs. Homeless service providers really need your help right now to identify those in need of assistance. So if you are able to ask your clients about their current living situation and identify potential housing instability, there are quite a few resources you can connect them to. You can either do that through homeless service provider or prevention services are often not in coordinate entry. So you might connect with your COC, you might connect with ESG programs, but there are a couple different ways. So one of the resources, which is not through HUD, is actually the Emergency Rental Assistance Program, which is funded. It's funding that was provided in response to the COVID-19 pandemic to assist households that are unable to pay rent and utilities. California operates a statewide program called California COVID-19 Rent Relief, which we provide a link to in this PowerPoint. But your local cities and counties may also have their own programs. So we really want to make sure that you're leveraging all of those opportunities. You can also, as I mentioned, tap into ESG funds, which are awarded to cities and counties. But the thing is that they have to say that they want to use the funds for homeless prevention. They can also use the funds for street outreach, rapid rehousing. There's quite a few different ways that they can use ESG funds. So a lot of places have set aside money for homeless prevention, but not all. So first you need to make sure that they have, and then you want to find contact information for your ESG funding recipients, and then find out if they're offering them, and if so, how to refer your clients. Once again, there is a link in here to where you can find grantees in your area on the HUD exchange. And then finally, we just want to acknowledge that housing instability is an incredibly difficult experience, and it can really exacerbate mental and behavioral health needs. So we just want to really make sure that we're providing that support piece and really providing those wraparound behavioral health services for clients if they're having this experience. There's also a number of points of connection that we can have between behavioral health and homeless providers to support street outreach efforts and meet clients where they are to provide needed services. I highlighted a few models here. We have multidisciplinary street outreach teams, which often include case managers, social workers, housing specialists, health and behavioral health specialists, and vocational specialists. So if your community has a multidisciplinary street outreach team, there's a chance you could be part of it. If not, then now is a really great time to create one. There is a lot of need out there, and there's absolutely opportunity. There's funding opportunities that can really support this. We also have street psychiatry, which is the practice of providing mental health care directly to people who are residing on the streets, in parks, under bridges, or in other community-based places where people experiencing homelessness may be found. I also highlighted mobile behavioral health clinics because those are just a little different from street psychiatry in that they often go directly where people are, but using vans and buses to set up services in areas like church parking lots, food banks, or other social service organizations so that they can reach high risk but hard to reach populations. So for site-based housing and homeless services, such as emergency shelters, congregate transitional housing, and single-site permanent supportive housing, you can also look into co-locating your services. So this looks like providing access to behavioral health resources on site in partnership with homeless and housing providers in your community. Options include having permanent co-location. So if you have a place that has some extra office space, you might be able to have an office in their on-site location, or it could mean coming on site with regular hours or clinics and setting those up in common rooms or common spaces or even outside. Once again, can utilize parking lots to provide those behavioral health resources where people are. There's also an opportunity to provide, to bring members of the housing and homeless world into your sites. Like if you have a physical location, you can bring someone who is able to do the assessments and connect people to coordinate entry into your location as well. And finally, there are a lot of opportunities for collaboration around serving clients in permanent supportive housing, since this housing is designed particularly for people with the highest housing and service needs. And that may include people with chronic mental health and substance use disorders, and it often does. We definitely see this as the intervention that is really providing the most housing and health supports, and really trying to get that stability for as much time as people need. Permanent supportive housing is also designed to operate using a housing first approach, which means that people are connected to housing without expectations of sobriety, drug testing, treatment requirements, or other prerequisites for housing. Clients should not be screened out due to having significant health, housing, or behavioral health needs. In fact, that's exactly who this intervention is designed to serve. And they should have access to voluntary, individualized, and flexible supports and services. Just the key word there is voluntary. Permanent supportive housing is very much about providing that support, but not doing it in a coercive way. So making sure people have access to behavioral health supports, but not forcing anyone into treatment or receiving services. As you can see, there are a lot of opportunities for collaboration here. It may include connecting clients who are experiencing homelessness and that you think would benefit from permanent supportive housing to coordinate entry. It may also look like partnering with permanent supportive housing providers to offer behavioral health services for clients, and also providing continuity of care for your clients who are housed through permanent supportive housing. Right. So that is the end of ours, and I'm going to hand it over. I think, Angela, you're kicking us over.
Yes, we have a lot of great questions. I'm going to start off with the first one. So the access to any official funding has always been tied to individuals who have status in the US. What about the vulnerable populations that don't have status? What options do they have at this point in time? And how can we help maintain the continuum of care in this context?
That is an excellent question. And so I will try and find the exact information that I can send you, but it really depends on different resources, what is available and accessible, but there are resources that are accessible to people who are immigrants or who are undocumented. So I am trying to do a quick search for that now, so just give me 1 second. But really, one of the things we also want to emphasize is that HUD does not require, sorry, I'm just trying to find this quickly, but HUD doesn't require proof of like Social Security or identification in a lot of cases. Those requirements usually come more from landlords. So if you don't need to require things like Social Security, identification, those are ways that you can really make sure that things are accessible. And so I did find that information. So that there is information in it was HUD, HHS, and the DOJ issued a joint letter reminding recipients of federal funds how the Personal Responsibility and Work Opportunity Reconciliation Act applies to their programs. So I will provide a link to that joint letter in the chat. But really what it delves into is that, I lost it, I'm sorry. But it delves into the fact that there are certain types of federal assistance that are not subject to the act and that don't place restrictions. So those are street outreach services, emergency shelter, safe haven, and rapid rehousing prior to annual evaluation, and COC program transitional housing. The ones that are subject to the act, which means that they would have to be people who are US citizens, are ESG rapid rehousing, ESG homeless prevention, COC program transitional housing, when the recipient or subrecipient is providing rental assistance payments on behalf of the program participant, and COC program permanent supportive housing. But once again, you are not required, charitable organizations and recipients of COC or ESG program funds are not required to verify immigration status. So I hope that that was a lot of information, and I'm going to try and provide some links in the chat for you, but that's some context for what you can do.
Thank you. Somebody mentioned in the chat that they said that in Massachusetts, the status is required to access Section 8 housing. And most students and families that they work with are not able to get stable housing.
Yeah, and unfortunately, public housing is a little bit separate from the homeless response system. I know that it feels like they should be very closely aligned, but public housing is operated through a different office of HUD. So unfortunately, they have slightly different requirements and restrictions around serving. So I'm sorry to hear that, but I do hope that at least this information can help provide some options in your community.
Thank you. Another question is, what if there are no COC contacts in my area and they live in Tulare, California?
Yes, and so your contact, I think someone shared this, is the Kings Tulare Homeless Alliance, and you would be able to find them. You can search for them, but also the HUD Exchange, which I will provide a link to as well, has a place where you can find your COC contact and your grantees. I will provide a little bit of a warning that sometimes those contacts are out of date. But usually you can find out who the main contact is, like what the main organization is, and then find their website and make that connection.
Great. Another question is, I have many clients who decline going through COC and our Department of Behavioral Health, which we work with individuals on their housing needs. They also decline staying in shelter. Clients get upset when I present these options. Is there anything else that I can do to assist?
This is a tough one. I'm gonna, not to put Katricia on the spot, but do you have any thoughts or ideas on this one? And then I'm gonna think on it, and we can also open it up to see if anyone else on the line has ideas.
Yeah, I mean, I guess my first question would be, why are they declining these services or not wanting to access these services? And what I've witnessed as a community psychology in the field is that it often stems from a distrust of government services or different kinds of programs, or when programs maybe weren't housing first or low barrier before it, and people thought that they would be forced to engage in certain programs in order to get housing, which is becoming less and less the case with housing first requirements and low barrier requirements or recommendations by HUD. So I guess I would check what the requirements are for these programs, and if it is housing first and low barrier and there aren't those requirements and that's a concern of your client, I would try to find some way to reassure them that that is not something that they will be forced to engage in. But also, I think, as we all know, it can take baby steps to rebuild someone's trust in a system that has continually let them down and was often the system that forced them into homelessness in the first place. So I think that there are different strategies that could be employed depending on the client and your community, but you know, I guess what I've worked a lot with youth, and what I've witnessed with youth is that when they have a safe, accepting place to go that lets them just be there, then they start to build relationships with the staff at those service centers, and then they eventually build some trust and start to seek help. And it can be a little harder with people who are in the adult continuum of care, so 25 and older, but you got to start somewhere. So I would say maybe attempts to engage in other kinds of services and try to help them rebuild some trust in a system that is trying to help them.
Thank you. Okay, another question is, housing and behavioral health are important components of homelessness, but what about the third major factor of incarceration in the prison system, housing, a large population that struggles with both homelessness and mental health issues?
That is a fantastic question. And I think we see a lot of communities struggling with a lot of the times this intersection is in a lot of tension. There's a lot of criminalization of homelessness, and there are policies that really disproportionately impact people who are homeless and have behavioral health needs. So I'm going to provide my response and then kick it over to Katricia if she has any thoughts. But I think one thing we've been really seeing is really advocating for that really intensive and progressive engagement and outreach through street outreach that police and criminal systems know about, so that they know when they are interacting with someone who is, experiencing homelessness and possibly having a crisis on the street, that the first resource isn't the criminal justice system, or it isn't to call the police, that there's support, there are street outreach, or there is street psychiatry, or there's a multidisciplinary team, which might include police, but that where they are not leading the charge, that goes to help that person and to try and avoid that connection to the criminal justice system. We do also see that once people, just like we talked about the cycle of housing and homelessness, like people, once you are connected to the criminal justice system, becomes so much harder to get out of that. So really trying to avoid that in the first place through these types of interventions is really important. And I just also wanted to comment on the part about helping people to engage. Also, just going back to the peer supports. Peer supports are so helpful at all of these stages, along with that progressive engagement. Katricia, any thoughts on this one?
Yeah, first I'll just echo what you said about alternative responses to calls that are made to the police or the government for people experiencing homelessness. An example is I come from Portland, Oregon. That's where I'm residing, and we have something here called the Portland Street Response, which is a totally alternative group of people that respond to those kinds of calls where the police are absolutely not needed. And they include mental and behavioral health professionals. But I think part of what I hear in this question is kind of two other issues where, for example, someone struggling with homelessness and mental health issues might use jail as having a place to sleep and be fed, and that it's better to be reincarcerated than to be on the street in some cases. But I also hear this issue of, for people who that's not necessarily the case for, who are maybe emerging from incarceration, then having no resources to get back on their feet into housing or to address mental health issues. And oh man, this is like a whole system-wide issue in the entire, with many different branches of government and many different aspects of communities, that I think requires kind of a whole government overhaul in some ways, and is not going to be accomplished by a local continuum of care alone. Things like banning the box, giving people like re-entry services to help them like get the education they need or get back on their feet in different ways. Those are unfortunately like beyond a lot of what a COC can do as they are currently funded and structured. But those are definitely super important things that are like a whole nother world of issues that need to be addressed as well.
And Katricia, I think that what you said about the issue of people maybe like going into or being reincarcerated to avoid homelessness, I think that is a really, if we are seeing that happening, or you're seeing that happen in your community, I think it's so important to get feedback from people who are having that experience about what isn't working for them in the homeless response system. Are they just not able to access it? Are the shelter options just not low barrier enough? They're not meeting their needs? Have they already been through the system and lost their housing once? And it's just, what is happening that's the experience for someone? And it takes a lot to try and address those issues. Like, it is definitely not an overnight thing. We totally recognize that these are huge systemic issues. So, but having those conversations is such an important starting point.
Thank you. Another question is, do you have any resources for clients in behavioral health needing legal assistance to apply for Social Security disability? And are you familiar with SOAR representatives?
Yes. So there is a website where you can find your SOAR representative. Once again, not sure how up to date it is, but I will share that here. The other piece I think is, even if it's not through the SOAR program, connecting with your local legal aid is super important, not just for issues around Social Security disability, but oftentimes there are other legal issues that might arise for people who are trying to exit homelessness. So connecting with your local legal aid, any kind of, and then any SOAR representatives, which I'll share that link. Katricia, any?
So we have time for one more question. What is HUD 811? And how long does it typically take to get permanent housing, Section 8 vouchers, et cetera, once applied through the COC?
I can let Alicia speak to HUD 811, but how long it takes to get permanent housing completely varies depending on the COC, the kinds of services they have available, how many beds they have available, how many people are coming through the system, how people are prioritized. Like, it completely varies. There's no way to really pin down how long it takes. I mean, sure, we could go in and do an analysis of, for all the COCs in the country, how long does this take? But I don't think that's actually useful information in regards to like understanding how it looks in your own community. However, your own community's COC should have access to that information. Those are analyses that HUD runs. There's like online platforms where they can gather that information. So if you wanted to know, you could contact your local COC to understand that.
All right, thank you. And so that's the last question that we have. And thank you so much for this opportunity to learn. I know for myself, I learned a lot from Alicia and Katricia in their knowledge and support and advocacy in this very important topic. So thank you so much for the information. And so I think since we wrapped up with questions, this is we're going to be wrapping up the learning session for today. And we really want to thank you so much for joining us. And please, I know Courtney put in the chat the survey information or the feedback form. Let us know. We want to hear from you as far as like any learning opportunities that you learned today, last couple of days, or any future opportunities that you, suggestions that you may have for the future as well. So take a moment and give us some feedback. So thank you so much for joining us, and have a great rest of your afternoon.
Thank you, everyone.